You're listening to Leverage.
To Leverage.
To Leverage.
An ASA Studios production.
Welcome to Leverage, ASA's podcast covering the politics of aging. I'm Amy Herr, ASA board member, co-chair of its Public Policy Committee, and Director of Health Policy at West Health. About a year ago, ASA and West Health released a special issue of Generations Journal on older adults and America's healthcare cost crisis. So much has changed since then, and the need to address healthcare costs has become more urgent than ever. Please join ASA and West Health as we talk healthcare policy and politics and get experts' ideas on the direction to take for better, more sustainable healthcare as we age.
Hi, I'm Leanne Clark-Shirley, VP of Programs and Thought Leadership at ASA, and welcome to another episode of Leverage, ASA's podcast on the politics of aging. Back in 2008, legislation was passed to authorize a new way of doing Medicare business, paying healthcare providers based on the quality of care they provide rather than on the volume of care. Since then, public and private payers alike have been increasingly moving away from traditional fee-for-service reimbursement to what we call value-based care models. And while that was happening, the use of telehealth and virtual care has been slowly growing. But of course, when the pandemic hit just about a year ago, the use of telehealth just skyrocketed. The Centers for Medicare and Medicaid quickly expanded access to telehealth for Medicare beneficiaries, and many private insurers followed suit as well. Now, there's been some speculation that healthcare organizations that already adopted value-based care models were able to pivot to telehealth a little more quickly. So today I'm joined by three experts who will talk through the intersection of value-based care and telehealth in the time of COVID, but also tell us how telehealth has changed older adults' access to care and give us some recommendations on what healthcare leaders and policymakers can do to continue breaking down barriers to virtual care that still exist. So two of today's guests are joining us from West Health, a family of nonprofit and nonpartisan organizations dedicated to lowering healthcare costs to enable successful aging. Amy Herr is here. Amy is the Director of Health Policy at the West Health Policy Center and is also an ASA board member. Michael Kurliand is here too. He's the Director of Telehealth at the West Health Institute. And we also have Jennifer DeYoung with us. She's the Director of Policy focused on health reform at the United States of Care. The United States of Care is a new nonpartisan organization committed to ensuring that everyone has access to quality, affordable healthcare. So welcome to Leverage, everyone. Thanks so much for being here.
Pleasure to be here.
And
Thanks, Leanne.
yeah. So let's get started. Jennifer, let's start with you. What's the difference between telehealth and virtual care? We hear both terms often used, but do they mean the same thing?
Yeah, thanks, Leanne. So virtual care serves as the umbrella definition to capture all healthcare services that are being delivered through technology. And that includes telehealth, as well as telemedicine, remote monitoring, video, audio, and instant messaging. It includes both synchronous, that is live two-way communication, as well as asynchronous, which is not in real-time communication, or also known as store and forward.
Okay, got it. So telehealth is part of a larger suite that we know as virtual care. Got it. So, okay, we know that telehealth and virtual care services grew exponentially over the past year during the pandemic. Michael, tell us more about that growth and what it looked like.
Sure, and thank you for the question. Well, virtual care was completely underutilized prior to the pandemic. And we can point to lots of reasons why. The main one starts way back in 2001, where Congress implemented what amounted to be restrictions and limitations for Medicare reimbursement. For instance, if you wanted to get paid, the patient had to be located at a healthcare professional shortage area or an area as designated as rural. And the patient had to be in a qualifying medical facility. And what really helped put a nail in the coffin is that telehealth could not be in the patient's home. There were more restrictions as well. And they were really put in place to discourage the adoption of telehealth within urban areas. So even with these restrictions in place, it was believed that without these guardrails, healthcare providers would overuse telehealth and run up massive amounts of reimbursements. To give you a little bit more context, the thinking back in 2001 was that like government accountants predicted that telehealth would cost $30 million each year for the first 5 years.
Okay.
But in reality, it's that it like racked up a whopping $20 million in the following decade.
Wow.
Not the $150 million they predicted for the first 5 years. Crazy, right? Mm-hmm. And another reason why telehealth struggled is that, well, you have 50 states, which means you have 50 different approaches. Mm-hmm. The good news is that one commonality is that all 50 states and DC provide reimbursement for some form of live video. But then the wheels fall off. It's like a hodgepodge of state policy. You have 18 states that provide reimbursement for store forward. You have 21 states that provide reimbursement for remote patient monitoring. And you have 16 states that limit the type of facility that can serve as an originating site. That's geek talk for where the patient is.
Got it.
Also, if you think about all these things, it's extremely confusing to providers, payers, entrepreneurs, and quite frankly, it's time consuming and expensive for them to figure it out. Mm-hmm. Now, over the years, CMS made some minor adjustments, but the cost of operationalizing telehealth didn't outweigh the challenges. So what did this all amount to? Prior to COVID-19, and this is something that really sticks with me, only 0.1% of Medicare beneficiaries use telehealth. That's not even 1%. That is 0.1%. Exactly. And so in comes COVID-19. And like you said, virtual care literally skyrockets in utilization. This is really enabled by the CARES Act in March 2020, which temporarily lifted many of those archaic limitations, particularly the geographic limitation that I mentioned, and allowed providers to charge for telehealth at the same rate as an in-person visit. And there were some other waivers exempting clinicians from really restrictive HIPAA regulations, which at the time of a pandemic is really important if you don't have like telehealth infrastructure and processes already in place. Right. One last point here, remember that 0.1% that I mentioned? Mm-hmm. And this is where it like blows my mind. Between mid-March and mid-October of 2020, over 24.5 million out of 63 million Medicare beneficiaries received a telehealth service.
Wow.
That's 39% of beneficiaries.
Up from 0.1.
Exactly.
That is a skyrocket.
And I'll just add, this is Amy. We did a survey in December of 2020 looking at older adults, many of whom have Medicare. And in our survey, we found that more than half of older adults had used virtual care services in the last year. Wow. 52%. And kind of exactly what Mike is saying, about a third of them had done virtual care for the first time ever during the pandemic. And one interesting finding was that, not surprising perhaps, was that older adults mostly saw providers they had already seen before, established providers. So it was like primary care and specialty care were the most frequent people that older adults had seen.
Mm-hmm. Yeah. So it's not like a lot of new care was established.
Right.
In that period. Okay. Well, let's talk about the theory of change. So how does virtual care lead to higher quality care and to better patient outcomes? Michael, how does that work?
It's funny. I never really get asked about theories of change, and it's kind of this. It's a great question, and it's fun for me to think about. I guess the one that really sticks out in my mind is from one of the forefathers of change management, who is Kurliand. And I'll be honest with you and every listener. One of the reasons why it sticks out in my head here is because it's like so simple and like, straightforward. So there's like, basically, here's the premise. There's like 3 steps. You unfreeze. Like, think about like before the pandemic, all those restrictions in place, and folks already had like their own internal biases in addition to the operational challenges of lifting up a telehealth program. So in your step 1 of the change theory, it's like, well, here comes the pandemic. We can't keep doing things the way we were doing. So we have to unfreeze, we have to change. And then comes step 2 of the 3-step process. It's really like the change or the transition. And this is where the action really, really happens. And then here comes step 3. It's refreezing or freezing. Basically, like, this is where I think the magic really happens. Like, the new norms, hopefully they have stayed there long enough where they become the new comfort zone, and they just maintain and sustain. And if I think about what's happened in our country and across the world and the pandemic, I look at it like this rubber band, right? Like, everyone, it's like, imagine just a rubber band sitting there, but then the pandemic comes and everyone, including healthcare professionals, families, everyone is stretching this rubber band. Mm-hmm. And this rubber band is doing amazing things and it's like doing things like it has never done before, different shapes. And if it stays in that position long enough, it'll be stretchy and different in other ways.
Yeah.
But if it doesn't have enough time, it'll spring back to where it was,
original shape,
to the old comfort zone. And that's what I'm really hoping does not happen with our current situation.
Yeah. Jennifer, how do you see this all fitting together?
Yeah, I love that rubber band idea there, Michael. That's great. When I look at virtual care, I really see it as providing an opportunity to address some of the long-standing challenges that many people have experienced with accessing the healthcare they need. And these are challenges such as lack of transportation to their doctor's offices, having to even travel great distances to get there, and then having to find appointments that fit around their work schedules. And I think it goes without saying that these challenges disproportionately impact certain populations.
Sure.
And if people experience barriers to getting the care that they need, then they're more likely to delay or forego preventative care or other healthcare concerns that they have. And then this increases the likelihood that they're going to develop an acute healthcare condition or use the emergency room when it becomes a crisis, which then ends up being really costly to our healthcare system. Yeah. And now with virtual care, people have another option available to them that helps them overcome these barriers so that they can get the care they need when they need it.
Yeah. Yeah, it makes perfect sense. And it sort of is simple. It's
Yeah. And let me just add, I feel like the genie's come out of the bottle, right? Mm-hmm. In the pandemic. So there's just no way we're going to be able to stuff it back in. Like we're going to have to move forward in a new normal. And so it's just a matter of figuring out what that looks like.
Yeah. Well, let's talk a little bit about, Amy. So it's been said that healthcare organizations that have already adopted value-based care models were able to make this pivot to telehealth more quickly. They let their genies out more quickly, maybe, of the bottle. Why do you think value-based payment makes such a difference when it comes to adopting telehealth?
So first of all, value-based care is really the idea of paying for value and outcomes and quality of care rather than instances of care, right? Rather than like paying by the service, by the visit, you pay for the outcome. And so people that receive care in that way and providers that provide value-based care really promote wellness and the financial incentives are focused on reducing costs and on better outcomes and patient-centered care. So I think that's really important as a backdrop. During COVID-19 last year, and continuing now. There were two real challenges for providers. And the first was financial, because in March of 2020, nobody was seeing their providers anymore. So the revenue just went way down for any kind of fee-for-service model. And the second was the care delivery was hard because, again, people could not literally come into the office to see the provider. So it was a huge challenge for the general fee-for-service system. But in a value-based care system, it was different. It was a really different experience. So value-based care, a lot of times you're paid upfront in a capitated arrangement. And so they were still getting the money in. So first of all, those providers weren't so stretched and stressed by the pandemic and the reduction in care and financial ability to do their work. But secondly, for the care delivery, they already had systems in place to think about outcomes and think about patients and organize their care with other partners and think about population health. And so these connections were already in place. So when the pandemic hit, they already had partners across the different systems, and they really were better situated to provide care, especially for older adults.
That makes a lot of sense. The news coverage of, the providers closing up shop because they couldn't sustain it makes a lot of sense if they've already invested in that sort of model and infrastructure that they'd fare better. Thanks. That's helpful. So, go ahead.
Sorry. So, some folks in the industry are really predicting that a lot more provider organizations are going to more aggressively look for these value-based scenarios and start to transition operationally and their contracting, because the pandemic has taught them that the value-based plans can serve as kind of an insulation from situations like this.
Yeah. Interesting. Well, we'll have to see what happens on that front. So this is all about helping keep healthcare costs down. So I'm curious, how do we ensure that virtual visits, after this is all over, how do we ensure that virtual visits replace in-person visits rather than simply just becoming a new category of care on top of the current system? Jennifer, what do you think about that?
Look, virtual care is not a standalone solution or a replacement for in-person care. But, if we want to see more people getting the care they need when they need it, rather than waiting until it's a costly emergency visit, providers should be offering a blend of virtual care and in-person visits for patients to choose from whenever clinically appropriate. Mm-hmm. And, some patients will prefer one type of visit over the other. And by having both options available is going to ensure that more people have the opportunity to get the care they need in a way that works for them.
Yeah, that makes good sense. And I think even just practically thinking, there are some visits that could be handled completely virtually and others where you do need the eyes-on in-person experience. Yeah. So let's talk about some of the work that you all are doing together. Let's get a little bit specific and practical here. So I know that West Health and United States of Care recently worked together to look at the experience of older adults with virtual care. Amy, can you tell me a little bit about that project that you did?
That sounds great. Thanks. We're really excited about our playbook for virtual care for older adults. And we focused on how virtual care could be used to address equity and access concerns. So we looked at older adults over the age of 50. And we really sought to understand whether virtual care was working for older adults, what the benefits were, what the barriers were, and how we could close those gaps in equity and access for older adults. And we wanted to make sure that we develop policy recommendations so that we could increase the use of virtual care and telehealth for older adults while ensuring that some populations aren't left behind by the digital divide. And so we really hope that the playbook can help inform both healthcare providers who are expanding their use of virtual care, but also policymakers as they're thinking about how this rolls out in the future, and make sure that we can increase access to virtual care, but do it in an equitable way.
Yeah. So Jennifer, tell us a little bit about your role in the study, what you learned, and maybe talk about some of the barriers that older patients have experienced.
Yeah, thanks, Leanne. Happy to. So for this playbook, we use several different research approaches to be able to connect with older adults and listen to them to understand what their experiences with virtual care has been like and the barriers and concerns that they face with using it. And our research found that during the pandemic, virtual care has been central to maintaining the health of older adults. And we also saw an interesting trend in how virtual care is perceived, that those older adults who've used virtual care strongly support it, while those who had not used it reported that they just didn't have a need for it. So, to us, this signals that the more widely virtual care becomes available, the more people recognize its benefit as an option for getting the care that they need. Now, that being said, also as part of our listening work to older adults, we did identify kind of 4 main concerns and barriers that popped out that really impact older adults' use of virtual care. The first is their comfort in using technology and digital literacy. Mm-hmm. The second is around quality and personalization. So in other words, some older adults felt like there's a lack of a personal connection to a provider with virtual care, or they felt that their unique healthcare needs wouldn't be met with a virtual care visit. Mm-hmm. The third one was around getting an accurate assessment. So in other words, some older adults felt concerned that their provider would miss something or couldn't conduct a thorough physical exam. Mm-hmm. And then the fourth barrier is reliable and accessible internet. So some older adults had limited, inconsistent, or no access at all to internet service to do a virtual visit. And I'll just say, though, that overall, we found that older adults, if given the choice, they shared that they would not choose to replace their in-person visits with virtual care altogether. Okay. But rather, they really would prefer to have a combination of both in-person and virtual care visits available to them.
Yeah, we talk a lot about the digital divide here at ASA, and this just plays right into that. But just one more reason to solve that divide. Thanks. So I know that West Health operates a PACE program of all-inclusive care for the elderly, the Gary and Mary West PACE program. So I'm curious if we could talk some specifics about how telehealth has made a difference for people that are served through that program. PACE, as many of our listeners probably know, provides comprehensive medical and support services in the community to people who otherwise might have to move into a nursing home to get it. So Michael, tell us about how West PACE has integrated telehealth into its operations.
Sure. And if I may just give a little bit more about PACE in general, Sure. I've been in healthcare for over 25 years, and I feel ashamed to say this, that I only have heard about PACE probably about 2.5 years ago when West started looking at PACE. Mm-hmm. So PACE stands for Program of All-Inclusive Care for the Elderly. And Gary and Mary West PACE, the one that, our PACE clinic, it serves northern San Diego. And it's just one of only 138 PACE programs operating in 31 states. And still to my shock, because it's a great program for people, is that there's only 55,000 participants across the United States in a PACE program. And I anticipate, as people learning more about PACE and just how effective it is for clinical and emotional outcomes for older people, is that the population that is being served by it will grow. Mm-hmm. It's a really innovative model. It takes folks 55 and older. It's certified by the state, and it also means, like, if you're in PACE, you can qualify for nursing home care, but instead of going into the nursing home, you live in the community and as independently as possible. It has an interdisciplinary team, which includes docs, nurses, nurse practitioners, social workers, therapists, dietitians, care aides, drivers. They all work together. They all share information, all to help keep the participant safe, happy, and healthy. And I'm part of the research arm of West Health, and I hail from the West Health Institute, but I do work with our PACE clinic. And in the wake of the pandemic, West PACE had to close its day center and dramatically reduce its in-person clinic visits to comply with safety and social distancing guidelines. So how do you serve all these vulnerable, older, how do you serve all these home-based seniors? And we had 120 of them at the time. So what we did was, in just a matter of weeks, we deployed some virtual care tools. And we basically compressed the implementation timeline from basically like 6 to sometimes 12 weeks to 1 to 2 weeks.
Wow.
It was amazing. This is where like that unfreezing comes into play. Like, like you let go of your old ideas. We have to dramatically change how we are taking care of folks. So let's have it and let's just commit to it. Yeah. So we did it. We had this like 3-pronged approach. We did these patient assisted video visits. We had basically a telefacilitator that would go and sit with the participant and facilitate a video visit in real time. Oh, wow. We also deployed, and this was very, very crucial in helping care for our especially vulnerable for social isolation, was this artificial intelligence like platform, which basically provided a way for our participants, especially the most vulnerable ones, to communicate with it really turns out to be like a puppy or a kitten, but they're communicating with it. And behind the scenes is a real person making responses. And this has had a tremendous impact. And even the caregivers have remarked on just how fun and interesting and how interactive it is. And then we also included something called e-consults. And this is a way for our providers at the PACE clinic to communicate with specialists and get some feedback and get some direction on how to change the treatment plan or medication plan for participants, rather than that participant having to leave their home and go to a specialty clinic. And that means, they might need transportation. They might be sitting in an office, and, even the offices are empty at this time. And this also would be contributing to some social isolation as well. Right. And also increasing the risk of exposure.
Yeah. Wow. Yeah. That it sounds like I love the 3-prong approach, some innovative ways of not only getting healthcare delivered, but interacting, breaking up the day, socializing to some extent.
Yeah. And it doesn't stop there. I mean, we have other things in the works, but just like that 3-step process, we want these to become the new norm. We want the organization to kind of like freeze with this new comfortable way of operating. And we have to remember that telehealth is just one thing that our healthcare organizations have had to integrate in a very, very fast and short period of time. And there's but so much capacity to change. So we're going to take this, we're going to solidify these steps, and then we're going to incorporate new things, which, for instance, I'll give you an example, is providing telehealth without the use of like a telefacilitator next to the participant, for instance.
Yeah. So, Mike, you mentioned the new normal and what you hope stays. So let's talk about that a little bit. Jennifer, what have we learned during the pandemic about telehealth that providers, payers, and even patients should carry forward even as we move beyond the pandemic?
That's a great question. So I'd like to reference back to this playbook that Amy and I've talked a little bit about. So as part of that, one of the things we did was showcase 3 older adult care models and talked about how they integrated virtual care during the pandemic and also addressed access to care barriers. And so these models that we showcased were the Gary and Mary West PACE, which you just heard Mike talk a lot about. We also highlighted the Avera eCare Senior Care, which is a full service virtual care program for older adults in skilled nursing facilities and senior housing. And then the last one was Landmark Health, which is a program that provides longitudinal in-home geriatric primary care, behavioral health, as well as 24/7 urgent care for seniors that have multiple chronic conditions. And across all 3 of these models, we found that there were several things that they had in common. First of all, they leveraged virtual care as an opportunity to extend the reach and impact of their in-person care. They also all operated under a value-based payment structure, which gave them ultimate flexibility to meet the needs of their patients. They also used telepresenters, or as Mike mentioned, telefacilitators, to help patients with their virtual care visit, making sure that patients were comfortable with technology. And, just these telepresenters, what they are, they're staff members that are present in person with a patient, usually prior to, or in some cases during a virtual care visit. We also found that each model provided clear and transparent communication with families and caregivers about the use of virtual care. And last, all of them had at least a very basic infrastructure established to support virtual care services, which then they were able to build off of to meet that huge demand that arose under the pandemic.
Yeah. So lots of examples of what you all are doing and what other models are doing to really improve care, even despite what we've been through over the last year. So where do we go from here? What are your recommendations for healthcare providers and healthcare leaders to move forward? Jennifer, let's start with you.
Yeah, so for healthcare providers that are looking to integrate virtual care into their older adult care models, what we recommend is, first off, adopting a value-based payment model. As we've talked about, operating under this value-based payment system really gives you maximum flexibility to provide the virtual care services to your adult population. Mm-hmm. Next, identifying which of your older adult patients will benefit from virtual care. Virtual care has the potential to effectively help older adults who previously faced barriers to getting the care they need. But at the same time, in some circumstances, an in-person visit may be the best course of care for some patients. Next, we also recommend that you consider including a telepresenter as part of your care team. As Mike and I have just talked about, telepresenters are a key part to making sure the visit is as successful as it can be, by supporting both technology needs for the patient as well as assessment process by the provider. And lastly, educate patients and providers on virtual care services. By creating opportunities to talk with patients and caregivers about how virtual care will be used to meet their care needs, in addition to embedding virtual care protocols into training programs that you have for all your staff, whether it be those staff providing virtual care services, in-person services, as well as administrative staff. Mm-hmm. All of these steps together are going to help you to eliminate confusion and also make sure everyone is comfortable using the technology and understands the role it plays in a patient's care plan.
Yeah, makes a lot of sense. Amy, from a policy perspective, what recommendations do you have for policymakers?
Thanks, Leanne. As we kind of move out of the pandemic, hopefully, and into the new normal, the overall goal that we really want to impress on policymakers is to reduce gaps in virtual care access and support building a better, more equitable healthcare system. Mm-hmm. So that's our, guiding star, right? And virtual care is a tool, right? It's not the end. It's a tool. And as we expand it, it's going to be important to ensure that virtual care can be used to expand access to people who are hard to reach, as Jen eloquently mentioned earlier in the discussion here. But at the same time, we need to protect against overutilization and low-value care that might come out of a fast expansion of virtual care. So we have three overall recommendations for policymakers. The first is within a value-based payment model, it's going to be really important to offer a mix of in-person and virtual care. Yeah. So, allowing the older adults in your model to choose, when which type of care is appropriate, and which they would prefer in consultation with the provider. Mm-hmm. Secondly, for individuals with complex needs, we need to identify additional supports to help them access virtual care. And we've mentioned the telepresenters a lot during this call. And are there other strategies that could be used to help facilitate virtual care as part of a patient-centered healthcare system? Mm-hmm. Yeah. And then third, just that we always need in policy work is just more research, right? We need to research the quality, the cost, and the equity implications of expanding virtual care models and compare outcomes compared to in-person care. Mm-hmm. And look at that by different geographies and different populations and just really doing additional research in this area. Yeah. And we want to look at lessons learned in the value-based payment models that could be translated over to fee-for-service as we move forward.
Yeah. Mike, how about you? Any concluding thoughts on recommendations or where we should go?
Yeah, sure. I have so many, but I'll try to summarize. And great points from Amy and Jen. Great points. I echo those. My main recommendation is stay with it. The shift to using more virtual care is inevitable. It is. It was inevitable before COVID-19. It just may have taken a bit more time, maybe 5 or 10 years. And I'll give you a few reasons why it's inevitable and that organizations like provider organizations, payer organizations really need to start focusing in on these models. Is one, as we all know, we have an aging population. People are living longer. That's great, but they're also living with more comorbidities. Mm-hmm. So people are sicker and they're living longer. The downside is that we're going to have decreased amount of clinicians, right. RNs, specialists, primary care providers. So when you look at these forces, you have less people. So you have a couple things that you can lean on, like you have people, process, technology. But if you have less people, you have to lean on the processes and the technologies. And that's where telehealth is perfect. It comes in, it won't solve everything, but it will alleviate some of the pressures of this inevitable demand.
Yeah. Yeah. Lots to think about, lots of challenges, but lots of promise here. We'll be keeping an eye out on telehealth policy and value-based care and looking to see if that rubber band stays stretched out. So thank you all for joining. This has been a great discussion. It's been great having you.
Thanks for allowing us to be here.
Yeah, thanks, Leanne.
Yeah, sure. So you can find out more about West Health, the United States of Care, and links to all of the projects and reports that we mentioned on our website. Thanks for listening to Leverage, and we'll see you next time.